Okay, we're joined by Paul Sharkey, Training and Communications Manager with Epilepsy Ireland. Paul, thanks a million for taking the time.
Thank you.
What's epilepsy?
Simple definition, epilepsy is a tendency to recurring seizures that originate in the brain, and an epileptic seizure, a brief and temporary malfunction of normal brain activity. That's the simple definition. It may sound a bit complicated, but it's important to get both aspects of it right. First of all epileptic activity is the result of a brain malfunction. Secondly, for a diagnosis to be made, the guideline is that a person would have more than one of these particular episodes. So a tendency to recur has to be established. Then what is happening to the person, it has to be established that these are the result of a brain malfunction. Very often, people assume epilepsy is a person falling to the ground, going into a convulsion. It is only one of many different types of seizures. So we need to be careful that we don't just brand epilepsy as one thing. It is an umbrella term involving many different things that can happen, but they are all the result of this temporary malfunction of normal brain activity.
Anything that happens in the brain, I think it may be fair to say, people categorize it as psychiatric or abnormal psychology, or that the person is just mad. That's a million miles from epilepsy.
It is. Unfortunately, the history of epilepsy, all of those things you mentioned, have almost been associated with a person with epilepsy. What we're talking about is the functionality of the brain. And I know there are people who talk about mind and personality, and then there's the mechanics of the brain. We're talking about the mechanics of this spongy mass that is sitting inside in your skull. The most complex organ known to humankind. We're still learning about it. It controls everything. Some people don't like the analogy, but it is like a central computer, controlling all motor functions, speech processing, me trying to make sense of what I'm going to say to you, you trying to make sense of what I'm saying to you. All of this is being processed by this spongy mass. The malfunction is where these cells miscommunicate. They can either send out bombardment of messages or they send out a confused message. I ask you the question, what is the colour of your eyes? You answer me. If I ask you what is the name of the height of the colour of your eyes, you get a bit confused because it doesn't make sense. In electrochemical terms, these messages flying around the brain get mixed up. You have this malfunction. In a computer terms, it would be the computer crashes. In epilepsy terms, the brain seizes because it can't deal with the confusion. And then depending on where in the brain this happens, you get your physical, as it were, manifestation of the seizure.
How common is epilepsy in this country?
In Ireland, we have a prevalence rate of 1 in 115, which gives us around 35,000, 37,000 people in between that over the age of 5. We did, Epilepsy Ireland did a survey some years back, and that's what we found. If you take in the under 5s, you're talking possibly about 40,000 people.
It's a big number.
It is. 1 in 115 is slightly higher than the general figure that's given, which is 1 in 200. The principal reason we believe for that in Ireland is that epilepsy can happen to anybody at any age. It's more common in people under 18 and then over 65, and that is where the bulk of the Irish population fits. So we probably have that higher prevalence figure than possibly some other countries do. And as population demographics change, so the prevalence may change.
Now, Paul, when it comes to treatments in this country, the Irish doctors, Irish physicians, Irish healthcare workers are among the best in the world, and I don't think anybody would argue that. I think when that conversation comes up, the real problem is gaining access to them, but that's a systemic problem as opposed to a clinical or a training one. When it comes to the treatment of epilepsy, what are the main ones?
Well, the primary treatment is anti-epileptic drugs. Some people might be eligible for surgery, but it has to be a particular form of epilepsy. You have to find scar tissue, basically surgery is removing that. So the primary treatment will be anti-epileptic drugs. It will be quite rare for somebody who has received a diagnosis not to be on some form of medication. Unfortunately, it doesn't work as simple as that. You're dealing with a very, very complex organ, the human brain. Everybody's brain is different, everybody's body is different. So while there are drugs which would be recommended for specific types of epilepsy, what works for one person may not work for another. So there can be periods where a person is, very often people will say to us, I feel like a guinea pig. the doctor seems to be chopping and changing. What the doctor is actually trying to do is find the right medication, the right dose of that medication, sometimes having to introduce a second, sometimes removing one and trying something different. So it's a slow process to try and get the chemical balance in the brain right, but that's the primary treatment.
There's the process known as electroconvulsive therapy is in the news recently. Is that something that could be used for the treatment of epilepsy?
Hard to say. I mean, there's lots of different ideas as to how epilepsy can be treated. The more we learn about how the brain works, we're still, despite all our advances, we're still in an early stage. So lots of different treatments may appear on the scene. They may work, they may not. All we can hope for is that research will give us a better understanding of the brain, a better understanding of epilepsy, and who knows in years to come what those treatments might be.
Paul, what is this row that we're hearing about in relation to generics?
Okay, we try not to get too complicated. As I said, the main treatment for epilepsy is anti-epileptic drugs. The row that is happening at the minute is the question of what we call generic substitution. And basically, to try and keep it as simple as possible, you have a branded drug which is the first drug that is manufactured by the company. When the patent for that runs out, people can introduce generics. A generic is essentially, to most people, the same drug, but the actual compound is slightly different. There can be a variant between 80% and 125% of your normal anti-epileptic drug. The problem is, epilepsy being such a difficult condition to manage, because you are dealing with the human brain, everybody's brain being different. The whole process of trying to find that right mix of drug, which I mentioned earlier, once you achieve that, any variation in that treatment can result in a breakthrough seizure. So a generic drug, while appearing to be the same, while on the package it says it's doing the same thing, that variant in the active ingredient may be sufficient. On the one hand, if it's below the 100%, it could lead to a breakthrough seizure. If it's on the higher end, it could lead to a higher degree of side effects. So the problem is, if a person has been prescribed a particular drug, they should stay on that drug if that's what's helped them achieve control. Any variation, ever so slightly, with epilepsy could lead to a breakthrough seizure. A breakthrough seizure, the implications could be, if you are seizure-free for a year, you're legally entitled to drive in Ireland. One seizure, you lose your licence. That could affect your employment prospects, your social mobility. So what we are asking people to be very, very vigilant about is what you have been prescribed, you stay on. If you've been prescribed a brand, you stay on the brand. If the doctor did initially prescribe a generic and that's working, stay on that generic and not on a variation of that generic. So the main message we are asking people in this row is to be vigilant. Try and ensure that your doctor prescribes the same drug as they prescribed the previous month. To write on the prescription, do not substitute. So the pharmacist cannot change the drug you have been
and
prescribed.
then you have to be vigilant with what is actually handed over the counter.
That's the next step. When you receive your medication, check that it is the same.
Yeah.
Keep the old box.
Paul, here's a generic question for you, and perhaps one that you won't even be able to consider because it's a bit all-encompassing. Given the fact that there is such a confusion, it could be argued with this issue, does that mean that this could scupper the entire generic plan if we use this epilepsy drug regime as an example?
I don't think so. I mean, Epilepsy Ireland is not against generic substitution per se. All we're asking is, because the evidence shows that epilepsy is a condition, it's described as a narrow therapeutic range condition, that you cannot have this variant within the drug regime. If you do, you could end up with breakthrough seizures. So we're not trying to scupper the plan. We know it will save an absolute fortune long term for the Irish government. We're not against that. We just want to ensure that people stay on the same drug.
Paul Sharkey, thanks for your time.